Thank you so much, Dr. Coleman. This is truly an honor, and thank you for giving us the opportunity to present our data. I am presenting on behalf of all my co-investigators, and I do think this is a very timely topic because people are not just concerned about the clinical outcomes in patients, but there's a lot of buzz around the economic evaluation of what we do. So what we are presenting today is the clinical and economic evaluation of the use of Denosumab versus zoledronic acid in the treatment of myeloma-related bone disease. Now, these are the disclosures of myself as well as my co-authors. And as you all know, everybody is familiar with the fact that multiple myeloma is characterized by significant bone disease. And we also know that the story of rank ligand has been best studied in the context of myeloma. We've just completed a very large randomized international phase 3 double-blind study called the 2009 482 study, which evaluated the efficacy of Denosumab when compared to zoledronic acid in newly diagnosed symptomatic multiple myeloma patients. And we followed this up with an economic analysis as well using the XGEM model. Now, just to give you a little bit of background on what the XGEM model is, the XGEM model is based on an original model which has been published already by Dr. Stopak, and this was a model wherein we've evaluated the cost effectiveness of Denosumab relative to zoledronic acid in the prevention of SREs. The study that Dr. Stopak did was in solid tumors, so breast cancer, prostate cancer, as well as non-small cell lung cancer, and her data did show that the Denosumab was in fact cost effective when compared to zoledronic acid with respect to SREs. So based on this Stopak model, we decided in this study our aim was to determine the cost effectiveness of this Denosumab relative to zoledronic acid for the prevention of SREs in myeloma patients. And just to refresh everybody's memories, this was the 482 study. It is, in fact, one of the largest randomized multi-center international efforts in the myeloma world, wherein we've accrued a little over 1,700 patients. We did stratify these patients based on their anti-myeloma therapy. We also stratified for whether they would get an autologous transplant versus not, for disease stage, as well as whether they had an SRE at the time of presentation or not. All of these were symptomatic multiple myeloma patients, and this was a double-blind placebo-controlled trial comparing Denosumab to zoledronic acid given every 4 weeks. We wanted to see 676 events on study, and if we saw a benefit, patients would be offered off-label Denosumab. If not, they would be followed for 2 years for overall survival. This is the data on the skeletal-related events. The study was a non-inferiority study, and we met the primary endpoint of non-inferiority, suggesting that Denosumab was just as good as zoledronic acid in reducing skeletal-related events in multiple myeloma patients. We did not see any differences in overall survival, whether patients got Denosumab or zoledronic acid, suggesting that survival was also equivalent in these patients. What we also looked at, and this was a pre-specified endpoint, but an exploratory endpoint, which was a progression-free survival, we saw a very significant benefit in terms of progression-free survival between Denosumab and zoledronic acid, amounting to about 10.7 months. Now, we've never really seen a survival difference or progression-free survival difference in patients, even in treatment studies, amounting to about 10.7 months. So this we found was quite remarkable in this study. Obviously, we also looked at safety, and I'm only highlighting the important safety issues for this economic analysis. What we found here was in patients, there was less renal toxicity if they received Denosumab compared to zoledronic acid, so that any renal toxicity was significantly lower in patients getting Denosumab compared to zoledronic acid. And in patients who had a creatinine clearance of less than 60, there was almost a doubling of renal toxicity in patients getting zoledronic acid. This was true for patients with a creatinine of greater than 2, and also there was a doubling of creatinine if if the baseline creatinine clearance was lower, suggesting that denosumab may in fact be the safer alternative, specifically in our patients with multiple myeloma, who we all know have this problem of renal toxicity throughout the course of their lifetime with myeloma. We then use the XGEM model. The XGEM model, as I've already pointed out, is an economic model that simulates the outcomes and costs of a cohort of patients who were diagnosed and experiencing SREs. We use the timeline from the time of diagnosis until death. SREs were evaluated every 4 weeks on this study, as were the study drugs, and costs were based on real-world data. This is the structure of XGEM. Patients were put in at the very start of the study, so on SRE treatment for prevention of SRE with their first line of treatment. They could either continue on the SRE, and some of these patients have progressed to go on to second line treatment. They could have had an SRE or come off treatment and continued on on a second line treatment, or gone beyond, and we followed these patients up until death. This model obviously considers the following outcomes. We looked at QALY, or the quality adjusted life years, in these patients associated with either SREs, adverse events, drug administration, or the multiple myeloma disease progression in itself. We also looked at cost of the drugs, so drug acquisition cost of zoledronic acid versus denosumab, as well as the drug administration and adverse event costs were all built into this cost. And we used both scenarios, wherein we used just the actual sales price of the drug, and no surprise to anybody, denosumab is a lot more expensive, nearly $2,000 compared to zoledronic acid. We also looked at the wholesale acquisition cost of denosumab to about $2,000, with zoledronic acid being $922. We did base this on SREs, and although I've shown you non-inferiority based on this, if you look at it numerically, this study did have less number of SREs in patients getting denosumab compared to patients getting zoledronic acid. Obviously, in the XGEM calculations, we looked at two things. One was the incremental cost effectiveness ratio, and those of us who are familiar with using cost analysis in the oncology world, we go by the WHO criteria, so that if your cost of whatever the intervention is less than $150,000 per QALY, that by WHO criteria is considered acceptable. We also looked at the net monetary benefit of this intervention of denosumab. The value of denosumab, we looked at it in two different ways, and we heard the earlier session where people were talking about cost. This is just the payer perspective. How much do you pay to get this drug? And if you look at just denosumab versus zoledronic acid and look at the sticker price of these two drugs, obviously there's a big difference. So this is what zoledronic acid would cost, and this is how much denosumab would cost. But obviously this does not tell the whole story. This is just the sticker price of the two drugs, and built into this XGEM model are a whole host of other factors, and these I'm going to highlight out here. And these include the cost of administration, the cost of adverse events, the cost of the number of SREs, the cost of treatment of a myeloma patient, and the quality of adjusted life years gained with either denosumab or zoledronic acid. And when you count all of these up and calculate all of these based on the data set from these 1,800 patients, we found that there was really a difference of zoledronic acid costing a little bit more than denosumab, and that amount was close to about $6,000. Really, the future of oncology care should be to look at value of care provided and the societal perspective also. So we did build that into this model as well, and the differences here were we included, obviously, in addition to what I've just shown you, we also included a few other features, and these few other features include indirect costs, which are generally not regarded, and these are costs which include cost of physical therapy, cost of interventions, cost of sniffs, cost of bringing a patient to the hospital for an SRE, which otherwise do not get calculated. When we've looked at costs for time to next treatment or the treatment of myeloma, we've actually used the wholesale acquisition cost, and we've been very conservative about how we've calculated this amount for the treatment for myeloma itself by calculating it 50% lower than what it actually would be. And we've also taken into account things like benefits given to a patient in terms of not earning enough during that time period. We've calculated for all of those things. And despite that, we see when you include a societal perspective, we actually do even better. And this has not even taken into account what a patient's preference is in terms of getting a subcutaneous shot versus an intravenous shot. So in summary, based on this study, I think we've been able to successfully show that Denosumab did meet its primary endpoint of non-inferiority. We did see that there was no significant difference in overall survival. We were actually very surprised to see a very remarkable progression-free survival of more than 10.5 months in our patients when compared to zoledronic acid. And when you apply the XGEM model of net monetary benefit, we found a benefit of about a little over 10,000. If you just take the payer perspective, it's about half that amount. But in total, we still think it's more cost-effective to use Denosumab when compared to zoledronic acid in this patient population. So in conclusion, bone-specific benefits were observed, and there was a prolongation of progression-free survival. And in combination with this economic analysis, we do think Denosumab provides a very valuable option for patients with multiple myeloma. I'm going to stop there, and I'd be happy to answer questions.